So before any therapist is allowed to treat any ProSport Physio patient, they have to pass the final test. Now, this is our equivalent of the Navy SEALs Hell Week. Now, obviously it's not as extreme or as bad as that, but it's designed to replicate the stress and the pressures that the therapist is going to have to go under in the real world. So when a patient walks through the door with vague symptoms, how do they react? And that's essentially what Ollie's going to do today. And these patient scenarios are real scenarios that have actually come through the clinic. So Ollie is the patient. They have to take that patient now through that subjective assessment, make sense of the symptoms, understand what's the root cause of the problem, explain it to the patient, and then know where to start in order to create some meaningful change for the patient, prescribe them the right rehab exercises that's going to give the patient the best chance of keeping those gains between sessions. So you can see there's a lot to get through in 30-40 minutes, and for a new grad therapist it probably is the equivalent of Hell Week.
So today is going to be wrapping everything up together. So we've been through the subjective, been through the objective, done hands-on, done some rehab work. So now it's going to be how we tie that all together to make a initial assessment. So we've given them 2 case studies to work through this morning, and then we're gonna come together, work on that case study. I'm going to be the patient, and I'm just going to completely be out of there. I'm not going to give any cueing, no coaching throughout it. I just want to see how they respond as if there's a patient right in front of them, and just see what they're like going through the whole initial assessment. And then hopefully a bit of reflection time at the end to see what we need to work on going forwards and what's gone well.
We got given some case studies, so we did like group work to look at the full initial ourselves, and then Ollie worked through it with us, and then we did like a bit of like a mock initial assessment, and we both had separate ones. So I had like kind of my own patient, he had his own, and we like went through it as if it was like a real patient, and then like did feedback at the end.
So that would be more his proximal hamstring going into his hip.
Yeah.
So a bit of proximal gastroc. It will be the whole of his hamstring, but mainly central to his proximal.
So then when it's toes down, is that mainly distal hamstring?
Yeah, exactly. Yeah.
Right. So you come in with lower back pain, start because you went back to running. But obviously 14 months ago you did tear your hamstring, so I do actually think it is probably connected. I know you did do some rehab, but you probably went back to running a little bit too quickly.
Basically because of my hamstring repair 14 months ago, I went back to running too quickly, which is then causing the lower back pain, which is meaning that my hamstrings aren't doing as much, taking as much of the load as they should. Sort of ran through, so Ollie sent us 2 mock patients basically. And me and Hannah went down there and we sort of planned what we were going to do for that. And then, so we did that in the morning. Ollie came down a little bit later on in the morning and just helped us out if we had any sort of questions or anything.
Would you do it all kind of separate?
Yeah, I probably would, because then you see what gives them the most amount of benefit. What you could do then next is like, okay, well I've treated the MTJ, which is important, but I might now start going in between the muscles a bit higher up as well. So you can go through almost the junction between. So as I palpate through here, when that force enters the muscle, when its contraction happens, you're going to have a large majority that goes to the MTJ, but then you also have some stuff that moves to adjacent tissues. So sometimes if you've treated the MTJ and it's not changed, it's improved a little bit, not perfect, go after the adjacent tissues a bit more, so go in between his hamstrings.
Yeah.
Okay, so try a few of those.
Yeah.
Good. Firm but fair?
Yeah.
Good. Go harder.
So the whole purpose of the case study scenario is for the therapist to be put under extreme pressure, but also for the head physio to inspect what we're expecting. Because it's very different when you're sat down across from another therapist, you're having a nice cup of coffee. This is what I would do. Whereas actually this, in this scenario, is what you're actually doing. So it's not what you want to do, it's actually what you're doing. And that's essentially what we mean by we're inspecting what you're expecting. Because on this spot, when you have a patient in front of you, it's a very, very different scenario. And that's really what we're trying to replicate with these case study scenarios.
Yeah, it's perhaps you just need to do it over and over and over again. So that's fine. You'll get better and better at that the more you do. You need to get yourself feeling a little bit uncomfortable with it. So don't ever shy away from doing it. If you fuck it up, just do it the next time you see the patient. It's not the end of the world. You just reflect on it, be like, okay, what could I have done better? When you go into their follow-up, you almost redo it again for them. So you just get sharper and sharper at it. Okay.
I feel a lot more confident than I was last week, but I'm still obviously a bit nervous going into it. But I think once I get into it, like, I'll be fine and like all my nerves will settle a bit more. So excited really, but nervous.
Then what do you think we should aim for after it and left his arm over his head?
I'd love to be able to pick my child up.
This one. Back up, and then twist forward a little bit. And then just arm down the side, and then the other. Any pain when you do any of these?
No.
And then just extend your chest, lean back forward. Right. Foot, shoulders. Right. With this, we were speaking. I'm thinking bicep tendon straight away, but golf elbows are what you think forearm.
Why are you thinking bicep tendon?
Because your bicep lengthens in every single one of those.
Yeah, nice.
But then the golfer's elbows throw me off of it because I don't really have anything to do with bicep.
Why does that not have anything to do with bicep?
Because it's more forearm.
Why do you think the golfer's elbow might be there?
Watch your arm, get a bit of weight with it. Smash. Right, can I get one here? Back forward.
Jesus.
Just a bit of arm out for me, slide bend your elbow, slide bend your. Perfect. This my first. Just turn your arm around and this my first.
Just make it easy for yourself. Just go same position, so kind of try and almost bring your little finger up towards you. So that's always me supination, and then do the opposite way, so go from that way. So that's probably the better handling you can do, because you can... I mean, obviously this is the important step for us, because this, from an onboarding perspective, it allows us to decide whether or not we need to give them more time before they start treating patients, or whether or not they're ready to go into it. So I think these kind of mock scenarios, although they're quite high pressured and it feels uncomfortable because it's not a real patient in front of them, if they can do a full assessment with me in the room and they're comfortable with that, I'd be very, very confident they can manage with the patient in front of them. So today's almost like the test to see how they're going to shape going forward.
That's maybe a 10. Really sure to do 40. So, that's what's causing your shoulder pain. So this is a plan at the minute, and we'll be able to lift his arm and get back to the gym from here. But I would recommend it as your pain then to come back. Do you understand what I'm saying?
Yeah, fucking, I go weeks before, anything months before. Like, these things can take time. If someone's having a new job, they started 3 months ago, so you want to really delve into this, because there's a gap here that we don't know enough about. Okay? So yeah, definitely ask a lot about that. Maybe just screen off medical history. Just be like, if you have any surgery for anything or anything like that, but I don't know, you might imagine.
Obviously, you've got your pre-assessment form, you've been getting right side shoulder pain. Then you've said this sort of came on about 3 months ago when you were pain in your house, you noticed it aching. Sort of what position were you in when you first sort of noticed it aching?
So I was doing all different positions, doing a lot on the ceiling, basically the whole room. So I was feeling it more when I was doing more overhead on the ceiling. I kind of just felt like it was throbbing at the time, but I was kind of expecting that. But ever since I've stopped the painting, it's been really sore ever since. So it's just never like calmed down. So a bit like a throb, I guess. Like I feel it loads when I'm driving. Like I have to drive a lot for work and things at the moment. It just kind of like aches and throbs in the background.
Getting quite irritated at the minute. So I'll do a bit of an assessment of you, and then we'll...
You'll notice also as we go through this process with the therapist, and even as we debrief the therapist, we never actually give them an answer. And that's really where we want to instill the coaching habit inside the head physio system. So that's where any question that they have, we very much go back to them with a question. And that's very deliberate so that there's some active processing happening. Because again, essentially a lost art is clinical reasoning. And in this day and age where therapists have access to ChatGPT and a whole host of things, the actual art of thinking is slowly fading. So what we want to do with our therapists is we want to differentiate them from everyone else by being able to critically think and problem solve.
So it's going to do just some shoulder movements. If you just put the facial forward, just lift your arms up. Getting any pain there?
Yeah.
At what point are you getting the pain?
Probably there, it gets a bit sore.
Okay.
Kind of eases off a little bit as I get to the top, but it's quite sore just around there.
Move right, and if you just go to each side for me. Move right, one side. Anything there?
A little bit tight, not as bad as going forward, but a little bit tight.
Move right, and if you just have a lean back to it. Anything there?
Yeah, that feels quite tight.
All where?
Kind of just feels like I'm squashing down on that right side a bit.
Okay.
Just somewhere around here, yeah.
So if I know I'm going to do it again. Pain that?
No pain, no, just don't feel very strong.
Okay, let's do it.
It was good. Obviously, it's going to be different with an actual patient because Ollie knows what you should be doing. So it's almost more pressure when it's Ollie than it is a patient. But yeah, it was good sort of being able to run through it because each day we've gone through a certain bit. And then today we've kind of linked it all together. So it was good getting the opportunity to do that.
You just built the pressure through your toes for me into my hand. Build it nice and slow, and as I'm pull up, can you just bring my pressure through?
Bit of pain there, but it's feel right, yeah.
Okay, smashing. Yeah, forearm doing 25, your elbow doing 25, your bicep doing 25, your shoulder doing 25.
Okay, yeah.
So that should be happening where it's taking equal load through of your arm.
Yeah.
This is what's happening here, which is causing that pain in the shoulder because it's having to overcompensate because it's not doing that.
So if my bicep got stronger, would my elbow get better?
In theory, yeah.
Yeah.
Because it then takes the slack off your forearm and your shoulder as well.
Yeah, okay.
What's it like? I can get you to try and bring your arm to your shoulder. Then relax it. Let me know if the pressure's too much. You're getting pain in there.
It's all right.
So we're going to go for 6, between 6 and 10 of these.
Yeah.
How did that initial sort of assessment go with Ollie?
Not too bad, to be fair. Obviously, we had like little things that we both could have done better. But considering how I felt when I first started to, like last week to now, like I just feel so much confident in it.
Flip one.
And back up. And down. And back up. And down. And down. Lovely, and back down. So you're saying when you are driving, is it irritating your back or hamstring more? Would you say? Like
A bit of both, but I'd say it probably aches my back more. Just the pressure of being sat hurts my hamstring.
Okay, so you feel like you need to kind of wiggle it
Yeah,
out.
wiggle around a little bit, yeah.
Okay. The curveball, so obviously we had time to plan it, but we didn't really know actually how Ollie was going to respond. So then having the response and like it throwing you off a little bit and then planning how you'd then kind of deal with that in an actual situation with the patient. And then in regards to running some short distances, like what is kind of your goal in regards to running?
I just want to be able to run like the occasional 5k this year. I don't want to do a marathon or anything like that. I just want to be able to go out for a jog.
Yeah, so we'd probably start off with a jog, maybe a 1k from there.
Yeah.
And then as we get past the run and get to 5k, we are looking closer to here, but probably have a few more, like maybe agility and looking and stuff like that.
Yeah.
Does that sound okay?
Yes, it's good.
Yeah. So in regards to how your back is therefore to get to that 100% is overcompensating.
Yeah.
So that's taking a lot of load, and that's probably why you're getting all this back pain.
Fine, yeah.
And the reason your hamstrings are probably quite weak is because of this tear front. So you did a bit of rehab, but even you said like you didn't feel like you ever got.
Yeah, it feels like it's never really got to the stage where I was confident in it anyway. Yeah.
Yes.
That's annoying. It's 14 months post-op now. So, yeah.
That's what you to hold it there for as long as you can. Are you feeling any pain when you're doing that?
No.
No? Is that right? You can do that?
Yeah, with this one, but I feel it a little bit more the twist.
Okay.
So this one feels alright, I can't feel it, but I can do feel it a little bit if I rotate a bit more.
Okay. Let's 6 to 10 minutes. Apologies. Let me know if the pressure's getting too much.
That's all right.
You feel like
He openly said that he threw a curveball in there, but yeah, it was hard, and I'd rather get it wrong now than with a patient. So it's just about, like you were telling me just down there like 2 minutes ago, it's taking a step back and sort of thinking about what's doing what and what's should be doing something, and if it was doing it, then what would solve the problem, sort of thing.
how's that feeling?
Yeah, fine.
Pushing against me. Still getting down.
Yeah.
Okay.
So just pause 1 second. What needs to work there?
Oh, you anterior deltoid pec.
No.
No.
What needs to work is to do that. Because now I'm in a medial rotation, my pec's almost fully shortened now. And I'm doing that movement there. So what needs to contract?
You've heard that.
Rear delt definitely will. What else?
Trust.
Yeah. And triceps probably the one I'm treating. Right?
Yeah, so do you understand everything that's going on?
Yeah, think so.
Can you repeat that to me?
It's probably still just all down to that hamstring repair that's not doing a good enough job, and my back's just compensating for it.
Yep.
Yeah.
Yeah, and you're all happy in regards to the plan and where we're going with that.
Yeah, sounds good.
You got any questions?
I think so, yeah.
I've been with no pain for over 30 minutes,
Yeah.
as obviously you've mentioned.
Yeah.
Smashing. So that sounds like a good plan to you? Do you understand kind of where we're going?
Yeah, sounds good.
So what we're looking at to sort of try and get to this end goal, it would probably be 8 sessions.
Okay.
Some people do it in less, some people do it in more. It kind of depends on the person.
Yeah.
Is this what you were expecting? We expected to do?
I was expecting to be seen a few times, I guess. Would you need to see me weekly or?
So once the therapists pass our Hell Week variation, then essentially they're ready to go and treat patients. And this is a great moment that they come through the other side of this intense onboarding experience. And, you know, for the last 4 to 6 days, they've been under a lot of pressure where we've been quizzing them, we've been asking them questions, and they've had to use their brain, they've had to clinically reason, they've had to problem solve, they've done a lot of doing and not just a lot of watching. And I think that's really what differentiates the ProSport Physio and the Go-To Physio Head physio onboarding systems, is that it is a lot of doing and just not a lot of theory.
It's fucking difficult for the sake of being difficult. And mainly just wanting to see what you would do if that was the scenario, because you might not be able to clear all the KPIs. So I was trying to see whether or not you would go after my tricep, or whether you just say to the patient, look, this is going to be the main one we'll focus on today. I won't worry too much about this. We'll focus on that next time. So there's kind of 2 avenues you want to go down, because if you keep doing it and it just doesn't change, you almost want to protect your reputation a little bit and be like, right, I'm not fucking changing anything here, so I'm not going to just keep going after it. I'll just say, right, we've changed the main one, which is going to be important for your flexion. Let's just focus on that for this week, and then we'll see about that the next time. That then gives you a week to then go on the hub, find out what you need to treat to be able to get that one right. Anything else you think you did that?
I think just rushing it.
Yeah, I think it's just rushing it. Like, fuck me, when you've got a real patient in front of you, it'll be the opposite. You'll go really slow. So like subjective wise, I think we've done the subjective and objective in the first 5 minutes. So, and that's because you've prepped on what you're going to be doing. But like subjective wise, I'd probably be saying, right, okay, so you've told me that you've painted your house 3 months ago and started feeling a bit of pain. Can you just talk me through what was going on at the time, what you were doing? So those are the good questions, but I probably just want more information. Information really good, your questions were good. For steadiness, you can go harder if you want. Like, you can push a bit harder. You want to really make sure that they know that that's weak as well. So you want to make that really open. So the first time, I know it's practicing it, but first time I probably was here, and then you just move on to the next session. I'd almost be like lifting their leg right off the bed. Be like, yeah, that's quite weak, isn't it? And then I'd almost be like, let's just check the other side. So that's actually something that you both would need to do, is always check the other leg as well. Right. So before I'd even look at the affected side, I'd be like, okay, it's your right side, isn't it? I'm gonna have a look at your left first to see what your normal is.
Oh.
Yeah, so
You rotate?
I'm gonna go back.
Oh, yeah.
So you'll probably feel that stretch.
Yeah.
Yeah.
I just can't get a lot of pressure.
Yeah. So again, and that's right. So I'll probably get your other hand on top of it, almost to give you a bit of support. And that's what I do for that.
Yeah.
Cool. Right at the end, I then might add that rotation there, which will stretch it a little bit more.
Yeah.
Okay.
How confident are you with treating your first patient?
A lot better than I was, but still obviously nervous about it. But we've gone through it a little bit, so I have got a bit of a plan like in my head. So I'm not going to be going in completely blind, and I'll do a bit more planning too. So.
Do you feel more prepared to see a real patient next week?
I do, yeah, definitely. I mean, this is the first time we've gone from start to finish. So if I had to go straight into doing that without doing this, I think I'd have been shitting myself a bit more.
So once the therapist gets through our version of Hell Week, they essentially have graduated from the phase 1 of the onboarding system, which is they're now ready to treat patients. Now, this is just the start of the onboarding process, obviously, because we're still in week 2 of a 12-week process. But what it does mean is that the therapist essentially has what we would probably call an MVP, which is a minimal viable product, in terms of they can do the basics to the standards that we expect them to do. So now we have to leave them into the real world with a real patient. And it's this transition now where the head physio dashboard and the other head physio systems are going to be absolutely critically important, so that we still have control of the quality and reputation of the clinic without being too controlling to the therapists. And so that's where now we're going to really rely on our head physio dashboard and our weekly and our monthly rhythms to make sure now that we keep that therapist progressing from week 2 all the way down to week 12, where they'll officially graduate from the onboarding process.